Growth hormone deficiency and hypothyroidism. Growth hormone deficiency types. Most common cause of growth hormone deficiency is idiopathic. It could be isolated and either congenital or acquired. Acquired can be due to trauma, tumor, infiltration, irradiation. Tumor could be craniopharyngioma or germinoma. Infiltration could be histiocytosis or sarcoidosis. Infiltration could be histiocytosis or sarcoidosis. Congenital could be development or genetic mutation. Development, ectopic pituitary, septo-optic dysplasia. Development could be ectopic pituitary or septo-optic dysplasia. Genetic mutation, growth hormone 1 and GHRH1, growth hormone release hormone receptor gene. Mutation in these genes can also cause. Due to hypopituitarism, Laron's dwarfism, due to defective GH receptor, resistance to effect of GH. Laron's dwarfism is due to resistance to effect of GH. Pathogenesis, growth hormone defective receptors on liver. There is no release of insulin like growth factor 1, insulin, and that's why there is no mediation effects of growth hormone. Characteristic feature is low levels of insulin like growth factor 1. Features isolated growth hormone deficiency. Normal at birth due to no role of growth hormone during fetal life. They are normal at birth because there is no role of growth hormone at fetal life. Then a proportionate short stature during infancy. Growth velocity is decreased less than 4 cm per year. Mid parental heights, it is minus 2 st from mid parental height. Doll like appearance due to decreased GH. Doll-like appearance is due to decrease in growth hormone, that is decreased lipolysis and deposition of fat, prominent cheeks, and overweight and obese. Bone age is delayed. Note, mid-parental height, genetic potential for height of the child. If associated with hypopituitarism, then there will be decreased gonadotropins as well. So decreased testosterone and other sex hormones, and then there will be micropenis and small testes and delayed puberty. If there is decreased adrenocorticotropic hormone, then there will be decreased cortisol and there will be hypoglycemia. There could be prolonged jaundice as well. Investigation, screening, IGF-1 levels. Maturation can alter IGF-1 levels. More sensitivity than IGF-BP3 binding protein levels. Preferred test when associated with severe malnutrition. Investigation, IGF-1 levels. Maturation can alter IGF levels. So that is increased sensitivity than IGF-BP3 binding protein levels. Preferred test when associated with severe malnutrition. Confirmatory. GH estimation, stimulative provocative GH testing. Random estimation unreliable as GH is released in pulsatile matter. Provocative substances, insulin, clonidine, arginine. Growth hormone less than 10 nanogram per ml after test is diagnostic. Treatment, recombinant growth factor. Subcutaneous injection usually given at night with epiphyseal closure. Other uses of recombinant GH is growth hormone deficiency, Turner syndrome, chronic kidney disease, small for gestational age for more than 2 years, S-Hox gene mutation, idiopathic Noonan syndrome, Prader-Willi syndrome, show catch-up growth within 2 years of age. Hypothyroidism. Importance of early detection. First 2 years, thyroid is an integral part of brain development. Low IQ if undetected and untreated. Congenital hypothyroidism. Most common preventable cause of intellectual disability is congenital hypothyroidism. Classification based on pathology. Primary pathology in thyroid gland, more than central pathology in CNS like hypothalamus and pituitary. Classification based on pathology. Primary pathology in thyroid gland is more than central pathology in CNS like hypothalamus or pituitary. So pathology in thyroid gland itself is more common. Etiology anomaly thyroid dysgenesis like aplasia, hypoplasia, ectopic thyroid, most common lingual. Most common overall is also thyroid dysgenesis, and also it's sporadic. Thyroid dyshormonogenesis, defect in organification, most common. Thyroid peroxidase deficiency, inheritance, autosomal recessive. Thyroid dyshormonogenesis, defects in organification, most common. So thyroid peroxidase deficiency, because of deficiency of that enzyme thyroid peroxidase, there is no organification of the thyroid hormone, that is called thyroid dysharmonogenesis. Inheritance is autosomal recessive. Severe iodine deficiency, endemic goiter or cretinism, it is seen in underdeveloped countries. Severe iodine deficiency like endemic goiter or cretinism. Maternal causes, transplacental transfer of maternal antibodies, TSH receptor blocking antibody, antithyroid drugs. Maternal causes. What is the maternal causes for hypothyroidism? Transplacental transfer of maternal antibodies like TSH receptor blocking antibody and antithyroid drugs. Features difficult to identify in early newborn period, first week, due to masking by maternal thyroid hormones. Features after 1 week, you will see decreased activity in child, wide open posterior fontanelle more than 5 mm, cold, dry skin, hypothermia, constipation, and delay of meconium passing, macroglossia, increased mucopolysaccharide deposited in the tongue, umbilical hernia, hoarse cry, prolonged jaundice. Goiter is usually absent in thyroid dysgenesis, can be present in dyshormonogenesis and maternal antithyroid drug usage. Investigation thyroid function test. You will see decreased T3, decreased free T4, and increased TSH. Screening infants is done in all infants. Heel prick dried blood spot testing. Increased TSH 2 to 4 days after birth. If more than 40 micro units, million units per liter, send for TFT, start treatment stat. If the TSH is more than 40, send the blood for further testing, TST, and start the medication as soon as possible. Radiological assessment, delayed bone age, epiphyseal stippling, dysgenesis, dot-like structures at epiphysis, not diagnostic of hypothyroidism. Epiphyseal stippling you can see here. It's dot-like structures. Confirmatory test, USG of thyroid, present, absent, or ectopic. Radionuclide study, isotope used is isotope used iodine 123 more than technetium 99. Radionucleotide study of thyroid, anterior markers, left anterior oblique, right anterior oblique. Treatment, oral thyroxine T4, to be started as early as possible. Dose 10 to 15 microgram per kg per day. High dose to promote brain growth. Goal, normalization of serum free T4, lifelong treatment. So treatment is by oral thyroxine T4, to be started as early as possible. Dose is 10 to 15 microgram per kg per day. High dose to promote brain growth. Normalization of free serum T4, lifelong treatment. Endemic cretinism, endemic to countries with severe iodine deficiency. There you find endemic cretinism. Neurological neurological most severe, very low IQ, goiter is present. Neurological manifestation, spasticity, squint, nystagmus, deaf mutism due to sensory neural hearing loss. Myxedematis, low IQ, loss of lateral one-third of eyebrow. Periorbital puffiness of facial edema. Goiter is usually absent. Acquired hypothyroidism, less common. Cause Hashimoto's thyroiditis, autoimmune antibody mediated damage, age and gender of adolescent females. Acquired hypothyroidism is less common. Cause Hashimoto's thyroiditis, autoimmune antibody mediated damage, age and gender is adolescent females. Features, first sign is growth retardation and short stature, constipation, dry skin, uncontrollable weight gain despite having poor appetite. Goiter is present, form nodular swelling, and delayed puberty. Management, thyroid function test, decreased T3, decreased T4, and increased TSH. Autoantibodies, anti-thyroid peroxidase and anti-thyroglobulin. Treatment, oral thyroxine T4, doses 3 to 4 microgram per kg per day for adequate doses, titrate with TSH levels, and requires lifelong treatment. We'll see adrenal disorders in the next video.